Everyone know during the next break is when we're going to have lunch. Yeah. Okay. So we're going to now start with Dr. Daniel Becker, who's going to be talking about critical issues in neurorehabilitation.
Thank you, everybody. So I will try to keep this a little bit shorter than the previous talks. And so maybe you have some, you're welcome. But I think it's going to be, I'm trying to lay out like some very important concepts that when we do neuro-rehabilitation in people with transversemyelitis that you should keep in mind. And so actually it would be nice if the room were full because the most important ones come at the beginning. So Janet Dean made a very important point that if you have transversemyelitis and you're trying to go and find a specialist for any field, for your bowel, for your bladder, including for a rehabilitation, and you say, I need a specialist for transversemyelitis, you will most likely not find them because they don't really exist outside of centers like us and maybe in Dallas. So, but if you tell them that you have a spinal cord injury, your likelihood of actually finding somebody who has expertise in that and what to do with you, it's much, much bigger. So this is one of my prime slides. I like to say that if you have GM, you have a spinal cord injury by definition. And so approach everything like that, and your doctors will be more comfortable with that, and all your specialists down the road. Okay. So what happens in a typical spinal cord injury? And this is a drawing we put together a little while back. So if you look at your spinal cord sort of as a longitudinal section, so your brain would be on one side and the rest of the spinal cord on the other side, you have wires that come from the brain that are in this blue color. They're called axons. And each of these wires has an insulation, which is called myelin. And most of you have heard about this. So the myelin is made by a cell. It's called an oligodendrocyte. And we're going to get back to that cell a little bit later. So don't get too scared yet. The wires are made by neurons that are sitting usually in the brain or in the spinal cord. So in transversemyelitis, as in like any traumatic spinal cord injury, you have an injury affecting every single one of these structures. Predominantly, it's the insulation of those wires. But some of the wires that are connecting the brain and the lower spinal cord are also affected. So if you look at the cord itself, you see this is the cord of a rat after a long time having had an injury, and you see a little bit of a cavity where the original injury had happened. And that's something we later see on MRIs too. Because people always ask me in my clinic when we do MRIs, I usually try to give them at least once a year after you've had transversemyelitis, and we see those white areas or scar areas, and people don't know what I'm talking about. And so this would be something, if you really want to know what it might look like in a rat model. So the other thing that we see in the area where kind of the borderline areas of where the injury was, you get a lot of inflammation. And where there's inflammation, there's a lot of scarring happening around the same time. And what happens too, that the cells, those oligodendrocytes that make the insulation, they suffer for quite some time after having had an injury. And they will try to re-insulate very crudely. And re-insulation doesn't always equal effective re-insulation. When you look at the wires of the nervous system, those axons, as like a cable in your house, and let's say it's a telephone cable, and you have to run, at least in the house, at least 3 lines, right, to make a telephone call. The new ones, I think, have 8 or 12, because you want to run a computer as well. So those cables, if you were them all, if they had no insulation, you would never be able to make a call, because these wires are just all bunched together, and they can't, there's a lot of short circuiting, so there's no way that this phone is going to work or your computer is going to connect. So that's why you need to insulate all these wires, and that's very important in the spinal cord too. But that insulation has to be done just right. So just having some insulation on there is not enough. And in most early repair processes, that insulation is made inappropriately, so it's not functional. Even if it might look like it has been reconnected, it may not be working right. And then you also see that over long term, some of those nerve cells that are connecting, that have lost some of their arms where they kind of reach out to other cells, they might die as well. And the other next big concept is to understand that if you had transversemyelitis and you think you had a lesion at, let's pick, like in this picture, like thoracic 9, so middle of your thoracic spine, you think that all your problems should just be localized to that one area. That would make sense, or everything below. But we've learned over the years that actually the spinal cord is affected everywhere, not only at that level, but all the way up to the top, like all the way, this would be here, the cervical 2, all the way down to your lumbar 5 spines. And what this is these are crosscuts of a spinal cord in a rat model. And so you sort of can see the butterfly structure in the center, which is the gray matter where all the nerve cells are sitting, and then you see the rest of the spinal cord on the outside. So I don't think that most of you look at a lot of spinal cords, but that's what it looks like. The white stuff in here, this is a marker for cells where there's inflammation going on. So you have months, and actually probably for years in a human spinal cord, there's continuously still the rest of the spinal cord affected. Okay? So we're not only looking at one level, because everybody always thinks, we have T9 or T10, wherever it is, we need to fix that. But actually you have to address the whole spinal cord. That's why when we talk about the rehabilitation programs, we're not only focusing on that one level where your problem is. We're focusing on every level below, including levels above. So, very important. Then this is a typical MRI of somebody who had transversemyelitis. So this was a 10-year-old child who had transversemyelitis, and this is a T2 weighted MRI. Who is very familiar with those MRIs? So if you look at the MRI, so this is a sort of a cross-cut of the spine. So like the way I'm standing this way. So I'm facing this way, you're taking a slice to me right through this way. My nose would be up here to the left, and the back of my head is back here. You see sort of the bottom of the brain. Then you see this gray structure that's coming down here, this stripe. And that is your spinal cord. Then there's a white stripe before and a white stripe right behind it. That's your spinal fluid. So we as transversemyelitis specialists, we are very interested in looking just at that spinal cord itself. And it should have this very boring gray type appearance, like you see it up here and like you see it down here. In this case, you see there's this white stripe here in the center. And so that's sort of a remnant of somebody who have had transversemyelitis in that very high cervical region. If you take a crosscut, so you cut it this way, and the spinal cord is this thing here, and you see that there's that little white stripe kind of corresponds with this area here in the front of the spinal cord. And so then the question always is, so what does it mean? You see this spinal cord, and what can this person do? With the current MRIs that we have, there is no way I can predict anywhere from this MRI what you're able to do currently or what you won't be able to do in the future. So those MRIs are really not anywhere helping us in describing your function or your prognosis. We obtain them on a regular basis to make sure that things are not getting worse, that there are no new lesions or that they're expanding that are in there. But those little white holes that we see here, this is what I showed earlier on the picture. What does it mean when you actually look at this under the microscope? For an advanced neuro-rehabilitation program, one of the biggest concepts is to understand that our spinal cord has the capability, has all the tools to do its own repair. So Dr. Levy is going to speak later about stem cells that we can transplant, but I'm talking here about stem cells that we already have. So there's a pool of endogenous stem cells that are sitting in our spinal cord, and that I can technically take out and I put in a culture dish, and they will grow any tissue I want them to do. I can take them out, I can stick them in the brain, and they will grow neurons and astrocytes or oligodendrocytes, like the prime cells. If I put them back in the spinal cord, they don't. So, or very, very inefficiently. So there's something inherent to the spinal cord that prevents them from doing their job right. And so for the last couple of years, we've been trying to try to understand what is that, what's so unique about the spinal cord environment that prevents them from doing their job. And so these are the cells we're sort of talking about. They look very pretty when you put them in a culture dish. You see the 3' cells. So number one is the neuron on the bottom right. The neuron is the sort of the wire of the nervous system. It has the cell body, most of them sitting actually in the brain, and then it's sent out their long, long arm all the way going down the spinal cord, which then tries to connect to the lower parts. The oligodendrocyte, or I usually just like to call them oligos, is a cell that reaches out and tries to insulate these wires. And one oligodendrocyte can insulate up to 40 to 60 wires. So by just getting rid of one, you technically lose connectivity in 40 to 60 of the adjacent axons. And the cell that sort of provides most of the support structures for nutrients and for everything else that's going on is the astrocyte. It comes in 2 types. There's this beautiful one that sort of is all very adherent, and then you have this little more star-shaped ones. So now the question is, what do our stem cells need to do their job? And so if you look at the same sort of type of picture we had at the beginning, where we have those axons, the wires are running this way, up and down the spinal cord. And then you have the oligodendrocyte, which is the yellow type of cell here, that reaches out and makes the myelin, which is little hot dog-shaped, almost hot dog bun-shaped structures. And so this is how the healthy nervous system would very crudely look like. In between, we have those red guys, and these are stem cells, and they're just sitting there. They are actually important every day to replace some of these cells that are dying naturally. When I went to medical school, I was told that the nervous system is static. You know, you're born with one set of nerve cells and brain, and that's it. We're going to die with that when we're 80 years old. Or some people get older. Men usually don't. But what we have learned over the last 10 years is that these cells actually, they work doing an incredibly hard job. So they work day after day. So they're actually turning over all the time. So there are cells that are dying and that need to be replaced. And so while we're all sitting here, we're making hundreds of thousands of new cells in our nervous system. And so there's a very good balance between cells dying and cells being replaced in the healthy nervous system. So what happens after TM or most of the demyelinating conditions is that those oligodendrocytes are site of a primary attack. So you kill one of them or two, and then you see what happens. Now with them gone, you lose the insulation on these wires. So with the insulation gone, so now the information going from one side cannot travel to the other side. Even considering the wire is extremely long, starts in your brain, goes all the way down here, if there's just a tiny bit of these hot dog buns missing, the whole wire doesn't conduct. And so what we would expect those cells to do, and let's look at the red guys, we want them to go to there where they're supposed to go, right? So once they're there, we want them to set up shop and become an oligodendrocyte. And then in the next step, what we want them to do, we want them to remyelinate. That's what they should do. And that's herein lies the problem, because they don't. So what do they do in most of the spinal cord is the cells actually, they can recognize that there's injury, and they actually move those stem cells. And then they just sit there, and they just don't do anything, or very incompletely. And so it took us a long time to figure out what do these cells need that they can repair, and where does the rehabilitation approach come in. And what we've learned is that those stem cells they do not know which wires they need to repair unless they're active. So if we activate these wires, make sure there's actually information going up and down these wires, then they can see them. And otherwise, they're completely blind for them. So you activate these wires, and now they become, if you go one step back, they become out of the stem cell, it becomes an oligodendrocyte, and now they will do the repair. So now the question is, how do we activate these wires? I mean, why am I talking about all this? The only way we have right now in a very advanced rehabilitation program is by stimulating those nerves with what we call functional electrical stimulation, or FES. So with that, you can stimulate the nerves from levels below, when I said from like, for example, the leg muscles, or from above, in order to actually get those wires activated. Once they're active, the stem cells recognize them, they can see what to repair, and then they will repair. And so if we, then the next question is, how much repair do we need? Is there a threshold? Can you be too active before you cause injury? And if you look at this graph, and it's a very simple graph, we plot activity to the right, and we plot regeneration to the left. So if you put you had TM here, so your activity levels are usually quite low, and your regeneration levels are low. So how do we push this one up the curve? So that means by increasing activity. And the only way of increasing activity is with an advanced neuro-rehabilitation program, which includes a very large component of a functional electrical stimulation regimen. And that's not something that you can just do. We specialize in that here at our center, but it's not something you just come to us and we're going to say, we're going to see you for 2 weeks or 3, and then we're going to say, great seeing you. Good luck. We'll see you later. These programs are chronic rehabilitation programs that you have to build into your life. Well, we can't expect for you to be here 365 days a year. I mean, it's not good for you because your life needs to go on. It's not good for your insurance will not cover this. So what we have to do, you have to sort of build this program into your life. And this is where we come in. So you come to a center like us. We build we call this activity-based restorative therapy programs, ABRT programs. We build the program, we decide which equipment is right for you. Which muscles do you stimulate? How long do you stimulate them? What activities do you need to do? How often are you going to do this? And then we send you home with an ABRT program that's all printed out, which outlines exactly what you need to do. And then you follow this at home. So optimally, always the question, how often should you do this? The TMA was very, is Chitra still here? No. Okay. We have several trials running right now. We're trying to figure out what are the optimal doses. But it looks like that from clinical experience, we know that an FES program 3 to 5 times per week seems to be the minimum cutoff. And that's 3 to 5 times per week for at least 1 hour each day. Okay. And we have now very exciting prospective randomized trial data that actually shows that there are actually things happening at the spinal cord level on a growth factor level that are really closely linked to those dosings. So every time I see a patient of mine, how often do I say? 3 to 5 times a week, right? Minimum. I have some patients that can do it 7 days a week. It's very hard for most people to do that. But ultimately, you want to build this type of rehab program into your life. And so then you do this at home for several months. And then as your function changes and the expectation always is improvement, then you come back a couple times a year. We update this type of program to your newest level. Figure out again, is it the right equipment? Are these the right stimulation parameters? Are there any different goals we try to achieve? And then we send you home with this program again. So we kind of create a lifelong relationship in regards to you from a rehabilitation standpoint. We kind of continue this on. If you look at it, we kind of continue this graph, there is no level of activity that we know is too much. The only limitations I see in my TM patients is generally fatigue. So if I put you on an activity-based program and it takes you 2 days to recover or 3 days to recover from this, then that means we have done a little bit too much. Then next time you do this, you back off a little bit. But overall, we know this is generally a problem when we start people fresh. Once you're on the program, that's generally not too much of a problem anymore, because you start building up some endurance with that. But we have been unable to show a peak where you say, after this much activity, it's getting worse. We have been unable to do this in humans. And we thought, well, if we can do it in humans, well, let's do it in animals. And so we had rats and mice, and we stimulated them for hours, at times up to 24 hours a day. And we thought we could maybe cause injury with that. We are unable to. Well, we thought, well, maybe if we can't do it in rats, let's do it in cells. You can do even more than and we were unable to do that too. So I still think that this curve is true. There is a peak. There's an optimal amount of activity. But I don't think that we can, at least for my patients, reach too much activity. Okay, so anything you can do to activate your nervous system, and preferably from areas below the level of your lesion, do it as much as you can. And there's no limits on that. I could bore you with a lot of basic science data that comes with this. I thought I laid out very, very broad. And I think I have 5 minutes. I can take questions. Yes. Am I? Oh, am I? No? Yeah. Okay. Because I think I'm 20 minutes. All right. Start here.
I've just started horseback riding lessons to improve my gait.
Mm-hmm.
Is that what you would recommend, or can you come?
So we know horseback riding is a very good therapeutic exercise, and one of the main things on horseback riding is your stimulation of trunk muscles. Because when you're riding on the horse, I fell off once. I never went back on.
I don't really want to get back on, but I do want to walk.
And Janet Dean has good. When we do it in kids a lot, it works very well. But yeah, it's because you end up give input into the muscles from below the injury. So,
is there a cutoff time for someone in my life? Say 18 months. No walk.
Thank you for giving me that question, because I forgot to mention that. So so the recovery from this type of injury never stops. There is no threshold that you say, well, you haven't recovered by 6 months or 18 months or 2 years or 3 years. Doesn't exist. You will find many doctors, for some reason, they like to give you those numbers. And you can even go in the literature, and actually there's some of the older that says, if you don't recover by 2 years, that's it. How did this data come together has been based on those assumptions. Generally, you freeze your recovery the time you stop rehabilitating. And that's usually what used to happen. People said, you're not going to recover anything after 2 years, stop rehabilitation. Well, yes, they didn't recover after that. So, but I have patients in my clinic that had injuries for more than 20 years, and you put them on programs like that, and you bring them back up. So no thresholds, never stops. Very important.
How do insurance companies view rehabilitation?
Actually, very favorably, because it's protecting from secondary long-term complications. There's good data out there that with these programs, you can actually decrease your risk of bladder infections. You can decrease the risk of skin breakdown, like pressure ulcers. We published a case report a couple of years back where we could show that a program like that actually cut down hospital stays by far. So we're slowly trying to change over win over the rehabilitation group. I think Sandeya might be somebody who has more insight into the politics, but you have to be very creative with your therapists. So you need somebody, because rehab all depends on goals, and most people forget that when they go to a rehab program. So that you are in charge. When I used to be when I trained and I had no idea about rehabilitation, I gave my patients a script that says physical therapy, eval, and treat. I gave it to my patient and say, "We'll go see somebody." And then you go there, see somebody, and then they give them the script and say, "Here, I should do rehabilitation." And then the therapist sits down and says, "Well, with you, we're going to do this and this and this, and these are your goals, and once we achieve them, we send you home." And then people got frustrated with that, because then the therapist determined when you're done. So what I'm trying to give you here, you have much more power than that. So because if you go there to your therapist, and I always tell everybody, you write on a list of things that you'd like to achieve. Just put 10 points on and prioritize them. And you say, I want to be able to, catheterize myself. I want to be able to walk from my kitchen to my living room, which is this length. Or I want, in the most extreme case, I want to play better piano. Or, but But you have to have a goal. And the therapists actually like that, because then you have a goal they can work on you with. Because there's so many things that are affected, and they just impose their goals on you, and they may not fit yours. So if you can show in therapy that you have goals that are achievable in the time frame that you have, then insurance is not the biggest issue. So we have been working with this for a couple of years back, a couple of years now. Dr. Sadowski has probably some input on that too. But she's battling with Medicare big time on this one. But it's getting, I think overall, it's getting better. 20 seconds.
Actually, one more question, but we do have other physiatrists who have talks, and of course, we also want to have more interesting discussion for our panel. So, last question.
Once you see a regeneration of so improved activity level, if there's a break or whatever reason, another illness, does that regeneration take memory, or do you lose it to start all over again?
So it's a very good question. So in people who develop more severe complications along the road, there is a risk that you lose some of the function you've gained. And so one of the big things that usually impairs this recovery is, for example, big pressure wounds that keep you unable to perform some of these programs. And I see some loss of function along the route. So that's why it's important. This is a chronic rehabilitation program that you can keep in. So even when you have periods of time where you can't do your program for whatever reason, at least try to be mindful of that and be as active as you can, at least to maintain what you have. I mean, overall, I would like to get you better, but the goal for those times would be, let's not lose anything, because that's a common thing that happens. Okay. Well, thank you very much.
Thank you, Dr. Becker. Again, so I'll encourage you to write down your questions, and that way it'll make for good discussion for our question and answer panel.